Okay, welcome everyone. Thank you for joining us in our Buncke Clinic Virtual Visiting Professor Series. I'm Bob Aksafa, along with my partners, Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin. I'd like to welcome you all to a very exciting talk this morning. We have the pleasure of having Dr. Greg Borschel from Toronto with us. He really needs no introduction, but I'm going to just summarize some of his background in the next slide. He's currently associate professor at the University of Toronto and also the Hospital for Sick Children, and as well as associate scientist at Sick Kids Research Institute. And he's also involved with the Institute of Biomaterials and Biomedical Engineering. He is currently the president of the American Society for Peripheral Nerve, and so we're very excited to be able to have him. And he's really a global thought leader in many aspects of neurosurgery, peripheral nerve, both preclinical basic science as well as clinical work. And his practice spans everything from the treatment of peripheral nerves in the extremities with traumas to treatment of the paralyzed face, and as we will hear, also corneal neurotization. He's done a lot of work on that as well. Did his undergrad at Emory, MD from Johns Hopkins, did his residency at University of Michigan, one of the premier programs in the country, where he also did a neuromuscular tissue engineering research. And then he did his fellowship in pediatric plastic surgery at the Hospital for Sick Children in Toronto, where he has been since. Greg, thanks so much for joining us. It's really an honor and a pleasure to have you, and we're really looking forward to your talk today.
Thanks, Babak. I really appreciate the introduction. I don't know who you were talking about. Whoever you're talking about there sounds really awesome. I'm just a regular guy. You know, my main job basically is cleaning up the ER and doing stuff that nobody really wants to do. But let me, should I go ahead and share the screen then?
Yeah, go ahead and share the screen. I think you're also being very humble, which is one of the hallmarks that we've seen of some of the great surgeons that we've had on this series. Perfect. We can see her that desktop, so you should be able to go full screen on that. And
how's this?
It looks perfect. Fantastic.
Okay, so you know, Babak, how do you want to do this? Do you want to do like Q&A at the end, or as we go?
Yeah, usually because it's a remote thing, it's sometimes hard to coordinate a live Q&A session. So go ahead and do the whole thing, and then afterwards we'll open it up for questions.
Perfect. Yeah, I think that really works very well. So again, Babak, thank you for the very kind opportunity to speak to your group, and it's a real pleasure, and seriously, it's a huge honor to speak to the Buncke group, one of the foremost leaders historically in microsurgery and globally known. So thank you again for that opportunity, and with that, I'll begin this presentation, which I think will be a departure for many people. Probably most people that are with us today have not seen this kind of operation. Maybe some have heard about it. So don't be afraid to ask what might seem to be kind of like weird questions, because certainly as I was getting into this, I had no idea what was going on. Like, oh my God, I'm a plastic surgeon and I'm like operating on the eye. This is crazy. But this is what it is. So the topic is corneal neurotization for neurotrophic keratopathy, which is a condition that we sometimes see. And of course, in plastic surgery, we're very connected. I don't know if people can see my pointer. Babak, can people see my pointer?
Yes, we can see the pointer very well.
Okay, perfect. So the idea is, you know, in plastic surgery, we're kind of central and we overlap with a lot of different disciplines. And in this case, it's no different. So here we're presented with what is really an ophthalmologic problem, and we're interfacing with them, collaborating with them in order to address a problem that's been vexing ophthalmologists for a long time. So what we're talking about is neurotrophic keratopathy, and this is what it looks like. This is the problem that comes up when there's no sensation to the cornea. So here the ophthalmologist has stained a corneal ulcer with fluorescein, and so the green stains the underlying stroma, which is green here. And then when these patients who can't feel their cornea go on to heal, ultimately they're often left with this dense opaque scar. And at its end stage, it looks like this, where the patient is not only completely blind, but also is disfigured by this white eye that they really don't like. And then sometimes they can actually go on to superinfection and perforation, leading to total loss of the eye. So here's an example of one of our patients. This is Daniel. He had cranial nerve 5, 6, and 7 injury from a skull base fracture. And the problem, again, is a degenerative corneal disease in patients with absent corneal sensation. And they are subjected to recurrent epithelial breakdown, and that results in corneal scarring and visual loss, permanent blindness. And this is a paper written by one of my collaborators here at Sick Kids. A lot of these patients have a coexisting facial palsy. And so as plastic surgeons, we will actually see these patients from time to time. And again, the visual loss that they have is inevitable. And the longer you follow them, ultimately they inevitably go blind. So to classify the severity of the condition, mild would correspond to irritation of epithelium, and it's reversible. Moderate would correspond to a shallow corneal ulcer, and these can also heal. If it's severe, then it's a deep corneal ulcer going down in the corneal stroma, and these patients often will result in permanent blindness over time. It's a rare condition. 1 in 2,000 people have this condition, but the majority of ophthalmologists will have a number of these patients in their practice, and it can be caused by congenital or developmental anomalies or acquired, such as tumors, which would be the #1 cause in adults, with congenital developmental being the #1 in kids. And we also see traumas and herpetic. Again, it leads to permanent blindness. The standard treatments from ophthalmologists are not curative. And then even a cornea transplant, you might think, would be curative, but the problem is if the patient can't feel the cornea, then they won't be able to feel the cornea transplant, and then that corneal transplant will undergo the same process and fail. And this is what it looks like. So these are the nerves of the cornea. You know, a lot of younger guys tend to think that other parts of the body are the most sensitive part of the human body, but the truth is that it's actually the cornea that is the most richly innervated part of the body. And you can see this very, very dense network of sensory nerve fibers throughout the stroma and the epithelium. And so this is a critical part of our defense mechanism for preserving vision. As I said, the ophthalmologic treatments are not curative. Probably the best among them, though, is the tarsorrhaphy. And here's a patient that's undergone a lateral tarsorrhaphy, and you can see that it does occlude the visual axis, and it's also disfiguring. So patients tend to not like tarsorrhaphies, and they like having them taken down. And this is one way to get there. So how did I get involved in this? I read a paper by Julia Terzis, which she published in 2009 in PRS, where she described what was basically a nerve transfer with her ophthalmology colleagues. And she did this in 6 patients, adult patients that had tumors. And this was effective in interrupting this cycle of ulceration of the cornea. But, you know, although Julia Terzis regarded this as one of her greatest contributions to plastic surgery, she also regarded it as one of her greatest disappointments because nobody really picked it up. Very few people picked it up. And part of the reason, I think, is because it required a bicoronal incision, which was not really acceptable to the ophthalmologists. Interestingly, there was a forerunner to this where Sami, a neurosurgeon, and Malesi, a plastic surgeon in Germany and Austria, respectively, back in the 70s, were doing craniotomies and occipital nerve transfers with sural nerve grafts to the ciliary nerve. So a big intracranial operation, but it effectively was targeting the same thing, restoring sensation to the cornea. So that's out there in the literature too. So we reasoned that a less invasive operation would be of benefit. Hopefully the main benefit would be that more people would opt for this kind of operation, and the ophthalmologic community would hopefully embrace it as a less invasive way to achieve corneal sensation. So this is what we did initially. We used the donor supratrochlear nerve and then coapted a sural nerve graft and then connected the sural nerve graft into the denervated cornea. And this is a very common paradigm that we've used anatomically. And here's a video that'll kind of walk you through. It's another early version of the operation. And here we are. The idea is we make an incision. If we can choose a variety of different nerves. We can use most commonly supratrochlear, supraorbital. We'll harvest a sural nerve graft. From the leg, we tend to use a series of small step incisions to do this. And now we're back up in the face. And in this patient, we're going contralateral. You can go ipsilateral and use a donor if it's available, but typically it's not. So here we're transitioning and tunneling the sural nerve graft across the face, and now we're going from a subcutaneous plane into a subconjunctival plane. We're doing this with a hollow tip needle called a right needle. So now we're bringing the sural nerve graft down, and now it's in the subconjunctival plane. Now we're going under the ophthalmology microscope. So I'm doing this with the ophthalmologist, Asim Ali, and I'm dissecting the sural nerve graft into its component fascicles, and we're using his microscope. So we can't use our plastic surgery microscope because the light is too powerful and it'll actually burn the eye. So now we're tunneling the fascicles of the sural nerve graft. He does this part. So we make a subconjunctival tunnel, and then we do this together. Now I'm assisting him. We're passing the fascicles under the conjunctiva and trying to cover the entire sort of clock face of the cornea, if you will. So we try to get usually like 3 fascicles if we can. If we can get more, that's fine. 3 seems to be a good number though. We tend not to do 2. We've kind of settled on 3 or 4 being more or less typical for this operation. Here, the nerve graft is being sewn in using interrupted tenovicral sutures. Again, this is all done under the ophthalmology microscope. And then the conjunctiva is closed again with tenovicral sutures. So everything's absorbable. There are people that will do this part using Tisseel, which I think is fine. We've only tried it a couple of times, but it seemed to work fine. And then often we'll put in a temporary tarsorrhaphy suture, and this suture is left in place for a week, and then it's taken out in the office. And then, as I said, we can use a variety of different donor sensory nerves to power this. Here, in this example, we've used the contralateral supratrochlear nerve, which is fine. We've used supratrochlear in many cases. We've used supraorbital nerve in many cases. If it's working ipsilaterally, that's fine. More typically, we have to go contralaterally. And then sometimes we have to use other nerves too, as I'll get into. We think it's really important to measure preoperative and postoperative sensation in the cornea and also in the donor dermatome. So you can measure corneal sensation using this device, which is called the Cochet-Bonnet aesthesiometer. And it's kind of like a Semmes-Weinstein monofilament, except it's a single gauge, and then you can vary the length of it. So when you extend it out to 60 millimeters, which is its longest length, then it's kind of long and floppy and exerts less force. And if you can detect this, then the ophthalmologist classify this as a normal level of sensation. And then if you retract the filament so it gets shorter and stiffer, then you get into the protective zone. And then out at 0 millimeters, this patient would be classified as having absent sensation. At the same time, preoperatively, we'll make a sensory map using Semmes-Weinstein monofilaments, just to make sure that the patient has dermatomes available for transfer. Usually for acquired cases, tumors and so forth, this is not much of an issue, but it's much more of an issue when you're looking at congenital or developmental situations where the sensation could be all over the place. Here's another example where we're using contralateral supraorbital. This is supraorbital nerve being transected and coapted to the sural nerve grafts. So again, you can use a variety. We've used supratrochlear, supraorbital, infraorbital, even great auricular nerve can be a good donor if you have to go there. So any available dermatome seems to be fair game. And then we do these coaptations either with sutures or glue or both. It doesn't really matter. And then the results so far seem to be equivalent. So in general, if you can find a good, healthy, robust donor, whatever it happens to be, then go ahead and use it. And again, in most adult cases, supratrochlear or supraorbital from the contralateral side would generally be a good combination. And again, the goal is to conduct new sensory fibers into the cornea. And here in the animation, we can see them kind of growing in. we've modified the technique in some cases where we've tried to put the sural nerve graft directly into the stroma by making a little window in the corneal stroma. And that may or may not help. We're not entirely sure yet. As I said, you can use a variety of donor sensory nerve sources. And as I said, it's best to use an ipsilateral source whenever possible. However, usually in acquired cases, this may not be available. And in those situations, then you should use a contralateral source. And as I said, we've used supratrochlear, supraorbital, infraorbital, great auricular. And the bottom line, I think, is to use a large donor nerve whenever possible. Allison Snyder Warwick, my previous fellow, has looked at this, which nerves are available for use. Supraorbital, supratrochlear, doesn't really matter. And we and now others have used a variety of different donors pretty much all over. And they seem to work. Others, this is a group in Vienna who looked at the use of supratrochlear or supraorbital. And again, either seems to be fine. They both seem to have enough myelinated sensory fibers and unmyelinated sensory fibers to make a difference. In terms of axon counts, it depends where you measure. If you look at the superior orbital rim, you'll get more fibers, so up to 6,000 myelinated fibers at the level of the supraorbital rim. If you go more distal, then you get fewer. So in our view, we wanted to harvest as many donor sensory nerve fibers as possible. So when we do this operation, we connect a nerve graft to these donor nerves at the level of the superior orbital rim for that reason. So we think that it makes a better nerve transfer than going distal to 3 to 6 centimeters. Here's an image from a review article, just looking at the geometry of the donor nerves and where they've been used. And our group, like others, has used ipsilateral, contralateral. We've done bilateral cases as well when necessary. You can run bilateral corneas off of one ipsilateral donor. So there's a plethora of anatomic considerations. Even great auricular nerve is one we've used. Now I'll just kind of walk you through a case. This is Abby, who's 16 years old. She was actually our very first patient 7 years ago. And she had a cerebellopontine angle tumor. And here she is on table. This is her affected eye, and then this is the donor. So we're going to make a donor site incision here. In this case, we use supratrochlear nerve. Here she is healed about a year later. This is the donor site incision. This is her affected eye. You can see this is before she underwent cornea transplant. And then she's got a little counter incision right here. Here she is about 3 months out. You can follow a tunnel.
All right. So can you tell me, when I tap over here, where do you feel it?
It goes here.
So she's got a nice tunnel about 3 months out.
So, and this is where we...
And then if you wait a couple years, you can see where the nerve grafts are. In direct gaze, you can't see the nerve grafts, but if you ask them to look down and then pull the eyelid up, you can see where these nerve grafts are placed, going around to the limbus. But most people can't see them just in casual conversation. We did a study looking at some of our early patients and followed them out for about 2 years. And if you follow them, what you see, if you make a heat map of their return of sensation, is something like this. So this is our first patient. This is Abby, who's the 16-year-old girl. Preoperatively, she had no sensation. And then if you follow her out to almost a year, then she gets to 60 millimeters of corneal sensation, which is a normal level of sensation. The sensation, you can't really say is completely normal, but they do have a feeling of sensation in the cornea. And then we followed others over time. This boy only got to about a protective level of sensation. This patient, who was developmental, achieved a moderate level of sensation, and then many others since then, and these are just some examples, have gone on to achieve a full level of sensation. This case actually was a bilateral over here. And so if we follow him out to almost a year, he gets to about 60 millimeters bilaterally. It also works in adults. This is an adult patient with a cerebellopontine angle tumor, and then if you follow her out to about a year, she achieves a normal level of sensation, and so she's able to interrupt the cycle of corneal ulceration and scarring. Here's a team photo. This is the original team. This is Asam Ali, ophthalmologist. Our first patient was Abby, and this is my senior partner, Ron Zucker, who's been a wonderful mentor and inspiration, both in facial paralysis, with a 40-year history of that, and he's also been very instrumental in kickstarting this program too. So here's a bit more about the collective outcomes of these patients and their corneal sensation. So early on, here we are preoperatively. These patients generally have no sensation measurable by aesthesiometry. And then you do the operation, and then when you follow them, most of them achieve a normal level of sensation. However, there is this middle ground where they get to kind of a good to moderate level of sensation that appears to be sufficient to really interrupt the cycle of corneal ulceration. And we have had some failures where they've either barely reached protective levels of sensation or really have not achieved an effective level of sensation. Fortunately, these failures appear to be rare, and we're trying right now to elucidate the cause of those rare failures. If you follow them in aggregate over time, and this is the maximal gain in sensation after surgery with Cochet-Bonnet aesthesiometry on the y-axis, and then post-op month on the x-axis, we can see that it really takes over a year. So here's a year out, here's a year and a half. It really takes about a year and a half to achieve the maximal gain of sensation that these patients will get. So we try to counsel them, this is going to be a while, and expect the final result to take a year or maybe even longer. We can also follow the visual acuity, and this is expressed in logMAR, which is something the ophthalmologist use. But the bottom line is that purely by restoring sensation to the cornea, or in the congenital developmental cases, giving it to them for the first time, it doesn't really alter their vision. So post-operatively, their vision is about the same as it was pre-op, which makes sense. What it does do is it interrupts the cycle of corneal ulceration, and it also sets the stage for corneal transplant, which I think is really exciting. So here's one patient who had neurotrophic keratopathy, multiple cycles of ulceration and healing with opaque scarring. And then this patient underwent corneal transplantation. And then here they are 3 years later. And this is really exciting because they have 20/30 vision, so pretty good. And then this white eye that they really don't like has been corrected by this, which they really appreciate. Here's some images of corneas. So when we've done the cornea transplants, we have an opportunity to take out the old cornea prior to neurotization in some of these kids, and then they'll undergo cornea transplant later. So then we can examine the neurotized cornea as well. So here's a sample of a patient after corneal neurotization prior to transplant, and we can see where the nerve fibers have landed. These are stained over here in this gold color. And in this case, these nerve fibers have landed in the corneal stroma. So somewhat trying to become a new stromal plexus, as it were. And then here's the cornea from prior to corneal neurotization. And again, this is a patient who underwent cornea transplant prior to the advent of this operation, and that's how we got this sample. So here there are no nerve fibers present in this cornea before neurotization. So as I said, some of the patients haven't had perfect recovery, so that's kind of stimulated us to try to figure out what's going on, from a neurophysiologic standpoint. And so that stimulated us to develop a rat model of this condition. And so Joseph Catapano, who is a PhD student in my laboratory, developed this model where you make a little hole and then put a bovie tip down here and then ablate the nerve that goes to the cornea. So a branch of frontal nerve going to the ciliary fibers. And so you can create an animal model of this condition. And then likewise, after denervating the rat cornea, you can neurotize it in in an operation that's analogous to the human one. In this case, we go contralateral, use the infraorbital nerve, and then use 2 nerve grafts to go into the cornea. And it looks like this. Here we are, here's the nerve grafts coming in, and then 1 nerve graft sewn in here, adjacent to the limbus, and then another one here. So here's an image of the rat cornea. This is the normal situation, normal rat, not denervated, and you can see this very rich plexus of fibers. There's stromal fibers, which are thick, and then it may be a little bit hard to see on your screen, but these finer wispy ones are the epithelial fibers. And then when the rat ciliary nerves are denervated, then you see ablation of most of these fibers. And then post-neurotization on the right, we can see a lot of these fibers coming in various parts of the cornea. We've also done healing assays. So in this situation, we have here in this experiment, we have a normal cornea here. So this is an innervated cornea. And then the epithelium has been removed and then stained with fluorescein. So that's why it's green. So wherever you see green, that's a wound. So at 24 hours, we see some wound healing, 48 hours, more wound healing, and then wound healing is nearly complete in the normal innervated situation at 72 hours. If we denervate the cornea and then remove the epithelium and then watch it try to heal, we see that it never really fully heals. But then when we neurotize the cornea, it recapitulates the phenotype of the normal, where we see wound healing occurring by about 72 to 96 hours. And then expressed graphically, what we see is that the denervated corneas initially try to heal, but then they stall out. At around 48 hours, they stall out and they fail to completely heal, whereas the uninjured, normal, intact, or the neurotized go on to heal almost completely by 72 to 96 hours. So something's going on. There's probably some kind of intrinsic factor with the presence of these nerve fibers that is in part responsible for maintaining the corneal epithelial integrity and ocular surface health. We've also seen that this approach can be used to prevent ulceration. And so what we did here was denervate rat corneas and then reinnervate them, and then remove a protective tarsorrhaphy to see what happens to these eyes. And we do fluorescein staining to look at breakdown and then look at scarring as well. So here's what we found. In the neurotrophic keratopathy state, once you remove the tarsorrhaphy at day 0, they go on to develop neurotrophic keratopathy or corneal ulceration. So here's an ulcer developing, and this is the size of it 1 week after releasing the tarsorrhaphy suture. But then if we neurotize these denervated corneas, then we see that the ulcer never develops. And then graphically, if we follow these out, here is when we've removed the tarsorrhaphy at day 0, and then we can see the wound size increasing in the denervated rat corneas over time, whereas in the situation where neurotization is performed, then we can prevent ulceration. So as both a treatment modality and also as a prophylactic modality, it seems to have an effect on corneal ulceration, either with treatment or with prevention. We can even see prevention of scarring over time. Here we are in the denervated cornea with a lot of corneal scar developed. And then in the neurotized state, the scar does not develop. And then we even see perforation in instances in which the cornea is denervated but not neurotized. And then with neurotization, we prevent the occurrence of perforation of the cornea. And this was statistically significant and published by Joseph as well. So we see that it decreases epithelial breakdown, prevents corneal perforation, and reduces corneal scarring. And so this in turn has informed our clinical practice, where we now feel that corneal neurotization should be investigated as a first-line treatment to not only address but also prevent the complications of neurotrophic keratopathy. So the implication in our practice is that if we get a call about a patient who has, say, had a brain tumor and now has corneal anesthesia and is at risk of developing neurotrophic keratopathy but has not yet developed it, we will still consider them a candidate for operation, and we will treat them on a prophylactic basis now too. Here's a nice little diagram. You know, we're trying to figure out in my lab and also on the clinical side what's really going on here. And it's kind of a frontier, you know, because nerve and the surface of the eye really haven't met so frequently from a research standpoint. But we hypothesized that the Schwann cell right here, these orange tinted guys, probably play a larger role than we used to think. And so that's one of the fundamental bases of what we're doing in the lab now. We're trying to see where these Schwann cells are in the cornea. And it turns out that there are indeed Schwann cells. This is a cross section of the cornea. There are indeed Schwann cells, even in the central cornea. And you can see them lighting up here, which is something that wasn't known before. The thinking was that these nerve fibers that go into the cornea are all unmyelinated and therefore don't have Schwann cells, but the truth is they actually do. Another question that we had was, how does the brain change in response to this operation? So we turned to magnetoencephalography to try to address that question. And this is kind of like, it's like a faster version of fMRI, where you can see regions of the brain lighting up to stimulus. In this case, an air puff to the affected cornea. So here, there's an air puff going into the right cornea prior to corneal neurotization. And then every air puff is represented by a little arrow here. And here we can see no signal here, and then nothing lighting up in the brain scan to the left. Here's an air puff to the right cornea after corneal neurotization. So every spike here corresponds to an air puff. And then on the image interposed on the MRI, you can see the region of the somatosensory cortex activating in response to this air puff, which is new electrical activity, new electromagnetic activity after this operation. And the air puff to the right cornea corresponds to tactile stimulus of the left forehead after corneal neurotization. And then here we're tapping on the left forehead and eliciting basically the same signal. So the brain in this case is sharing input from the somatosensory cortex of the left forehead, which is now directed into the right cornea. And this in part explains what the patients tell us after surgery, which is if we're using a contralateral source, say supraorbital, supratrochlear nerve, initially what they tell us is about 3 months after surgery, they start to feel something. When they're putting eye drops in their eye, it feels like they're putting eye drops on the opposite forehead. And then usually by about the 6 month mark, that changes and it starts to feel more like they're putting eye drops in their eye, which is typical for most patients. So there is definitely some cortical plasticity going on. There's some rewiring going on in the brain. And in most cases, this tends to work out pretty well in restoring a blink reflex. We were not so optimistic that this operation would restore a true blink reflex, but now as we've been able to observe many of these patients over the course of years, they do, in many cases, recapitulate what appears to be a blink reflex. And some will even have apprehension, as one normally would. If somebody is going in and trying to touch their eye, they'll have some apprehension and start closing their eyelids in response. So it does appear to restore or produce a degree of ocular protection. And again, I think one thing that a lot of patients really like is the ability to take down that tarsorrhaphy that's so disfiguring, and also the correction of that white eye, which the patients and families really don't like. Here's an image of the leg. This is how we harvest the sural nerve graft. We use generally 2-step incisions to do this. And then just to go over the indications again, I wanted to leave some time for questions, so I'll be wrapping up pretty soon. But the indications in our view would include acquired situations, most commonly brain tumors, and this would be the #1 indication in the West, certainly in adults and in children as well. Infections is probably the #1 cause worldwide, with that being leprosy. In the West, the most common infectious indication would be herpes, and then trauma would round out the majority of the acquired indications. With the congenital and developmental indications, most often it's a form of cerebellar hypoplasia or brainstem anomaly, trigeminal hypoplasias, these kinds of situations. But we've seen it with hydrocephalus and others as well. And I think the bottom line in terms of the indications is that any patient that presents with neurotrophic keratopathy or with corneal anesthesia is probably a candidate for this operation, unless if there's something precluding it systemically that would prevent their undergoing surgery. So far, we've done about 40 cases, and we haven't really turned anyone away with these indications. I do think that there are some important caveats, so I wanted to leave some time to go over these, particularly with the congenital developmental anomalies. There's a lot of variability oftentimes with the neuroanatomy. So a lot of times these kids and the adults that present with these developmental anomalies have a considerable amount of variability. So you may be looking for a supratrochlear, supraorbital nerve, and it might be small. It also might not be there at all. So I think it pays to be flexible and have a plan A and a plan B and even a plan C to go down to other nerves. And this also underscores the need for preoperative sensory mapping. So you'd like to know going into surgery that your plan A has normal sensation and your plan B, and hopefully you have a plan C. So I think that's very important to do the sensory measurement of both the donor sites, the facial dermatomes, head and neck dermatomes. And then, as I said, it's also very important to obtain the Cochet-Bonnet esthesiometry of the cornea, because that's what's going to help us track our outcomes and then ultimately get better at doing this. And then in turn figure out who's a really good candidate and who's maybe not a good candidate. The other caveat that I would present is that it's important to warn patients that around the 3-month mark, when those pioneer nerve fibers connect with the target cornea, they may have pain. And we would expect that they would have pain if there's instability of the corneal epithelium or a residual ulcer. And anybody that's ever had a corneal ulcer or scratch on the cornea knows how exquisitely painful this is. So if you warn them about it, then they'll expect it. And it's actually very reassuring, because it means that the nerve fibers are connecting and they're doing what they're supposed to do, which of course is great. The other caveat when you're doing this operation is be sure to take a long enough length of nerve graft and be sure to range the globe while you're doing it, because you want to make sure that the globe has full excursion. So don't leave the nerve graft short. You want to make sure that it's got a little bit of extra play in the nerve graft so the globe can move around freely, which is very important. A bit of a word on acellular nerve allografts. This has recently been coming up. People have started using them. I have no personal experience with this myself. I do think that over time this could present as a nice alternative to the use of autografts. And I think it would be wonderful to study, particularly in some of these bilateral cases, which, while rare, could be quite informative, particularly towards the use of AMITs. So I wanted to sum up and then hopefully leave a bit of time for questions. To summarize, this approach, putting new sensory nerve fibers into the cornea, appears to interrupt this otherwise inexorable cycle of corneal ulceration, which is really the key. So if you can interrupt that cycle of corneal ulceration, then you can achieve stability of the corneal epithelium. And then in doing so, after a number of months, it sets the stage for a corneal transplant. And therefore, this would enable restoration of vision, which appears to be permanent, basically. It does not appear to deteriorate over time. So the visual acuity achieved post-transplant is stable, which makes sense because now the new nerve fibers are supporting that corneal epithelium. Like many concepts in reconstructive plastic surgery, we're replacing like with like. So trying to use dermatomes, periocular dermatomes, to try to recapitulate as best we can the normal corneal epithelial sensory innervation. And then the last point would be that we're trying to use aesthetic reconstructive approaches to do this. So we use small eyelid incisions. These tend to heal fairly inconspicuously, and the patients don't complain about it long term, which I think has been an effective means of sort of broadening the applicability and the acceptance among the ophthalmologic community. The ophthalmologists were initially quite skeptical of this, and our first papers on this were rejected many times. However, now that we're 7 or 8 years into it, the ophthalmology community has really started to embrace it, which is encouraging. So to summarize, I've told you about the indications, a little about the operation itself. Thus far, it's been very low morbidity. We've seen some complications, but rare. As I said, we've had a couple of failures. We've had a couple of failures where we probably need to redo the operation. In terms of other complications, we've seen a few instances of donor site morbidity, pain from the sural nerve graft harvest site. Fortunately, that's been very short-lived. We've seen in our own practice and in consultation with others, some neuroma around the supratrochlear or supraorbital nerve donor site. This has responded well to occupational therapists doing desensitization therapy. Fortunately, we've not seen any ocular complications. We watched them quite carefully. Unfortunately, none have had reduced vision or disturbances in vision or neuroma or neuropathic pain involving the eye. I do think this is a wonderful story of teamwork. You know, as a plastic surgeon, it's been a real pleasure to work with Asim Ali and, of course, my mentor, Ron Zucker, who I mentioned. And then patients like Abby, shown here, are really grateful and quite vocal, actually, with other patients in encouraging them to try it too. We also have an international registry. So those of you who have done this operation, please, you know, drop me an email and we'll get you linked up with the international registry. If you'd like to get started doing it, drop me an email anyway. Happy to help as best I can. Asim Ali, the ophthalmologist I work with, is always delighted to talk to ophthalmologists, you know, anywhere in the world to try to get things started elsewhere. And, you know, we've gone to a variety of different places and others have come and visited and started programs. And this is, I need to update this slide, but there's now about 36 places that we know of that are contributing to this registry. And the whole goal of it really is to try to figure out who are appropriate candidates for this, what are the outcomes, how can we make it better in order to achieve the best sensation for people so they can enjoy the best vision possible, even though they're living with this condition. So I do think it's been a really, really fun journey working with the ophthalmologists. And I think this story kind of parallels stories from, you know, other parts of plastic surgery where, you know, we're working with kind of everybody all over the spectrum along surgery. And this is really no different. Through collaboration, we've been able to make some inroads on a condition that's really been quite vexing to the ophthalmologists for a long time. I think I'll just stop there and see if there are any questions. As I said, if you'd like to reach out to me directly, don't hesitate to give a shout, no problem at all. And I just want to thank the members of the team. These are the clinicians that I've been fortunate enough to work with over time. And then these are some members of my laboratory who have done a tremendous amount of work. There's even more that I didn't have time to present, but they've done a huge amount of work looking at this, you know, on the lab side. So I'll just stop there and see if there are any questions. Thank you very much.
Greg, thanks so much. This was an incredible talk. I'm getting a lot of comments talking about how great this talk has been. So we've had, this is our 36th talk in this series of really world-renowned experts, and I think I have to admit this is for me one of the most fascinating and interesting ones that I've heard. Really fascinating stuff. One comment is, let me turn You can keep your microphones up until you're ready for a question. That'd be great. Sorry, there's some background noise. First off, I love the T-shirt. That's awesome. And I think
Well, I think America needs a hero right now. So I feel like as an expatriate American, it's kind of my duty to to rep USA, because right now it's not looking so good. But when I come back, everything's going to be fine. We're going to get through this.
well, you're doing this stuff is superhero work, so I think it's appropriate that you're wearing that shirt. I think just first a comment before I ask a few questions. You mentioned that you got this idea from Julia Terzis, and you may have gotten the idea from a paper, but you've really taken it to another level. I think both clinically and basic science-wise with your experiments. So I really want to congratulate you on that. And just it's I don't do this, and my practice is pretty much mostly the extremities, but it's absolutely fascinating stuff, and I'm inspired to maybe try to do it and partner with some of our ophthalmologists here.
Yeah, I think it's definitely worth trying. And my practice is about 50% hand surgery, so
yeah.
I think that this is something, if you have the right ophthalmology team, then it's something that is within our domain as microsurgeons, upper limb surgeons. It seems weird, right? Like I never would have thought as a plastic surgeon that I'd be operating on like eyes. That's crazy, right? But
right.
It's just basic principles applied in a different way.
Yeah.
Is really what it is. And then to your comment about Dr. Terzis, she's been nothing but supportive the whole way. Really just incredibly encouraging, saying, initially I was doing side to end coaptations from the donor nerve into the sural nerve graft. So going from like the side of supratrochlear nerve into the sural nerve graft and then into the cornea. But then she said, you don't need to do that. Don't be, such a wuss. Go ahead, go ahead and just transect it, take the whole thing, go end to end. And then after that conversation, that's what we've been doing. And then I think your point is well taken. It's like one of these things where don't be so afraid of the donor site morbidity or the downsides of it, because what you're going for, you're going for something that could really preserve vision, or in some cases like set the stage for restoration of it. So I think her point is well taken.
Yeah. Yeah, I think kudos to her for coming up with the idea, and kudos to you for really kind of advancing in the way you have. I have a couple of questions. You mentioned a couple of the patients who did not have favorable outcomes, and we all have many unfavorable outcomes, especially with peripheral nerve. And the failure modes in the extremity are usually fairly predictable. Either you didn't go outside the zone of injury, or there was a technical issue potentially with the coaptation, or there was maybe an infection or whatever it is. And this is a bit of conjecture, but on this question. But what do you, if you were to guess, what do you think the failure modes have been in this case? Because obviously your supratrochlear nerve is a uninjured nerve, and everything. So do you think it's, what do you think it is?
Yeah, I think it's a great question. And so when I look at the failures that we've had, I had one where it was a 17-year-old guy with a severe closed head injury, and everything I tried to do on him failed. So I tried to do this operation. I tried to do a cross-face nerve graft, gracilis muscle transplant for his facial paralysis. I tried to rewire V2, V3, try to get sensation there, and everything I did failed. So I think he was probably depleted in neurons. Like donor neuron pool was probably just not so robust. And he also had cognitive deficits too. So I think in essence, it was insufficient donor axons. And I think the developmental cases that I've treated, and we've had 2 failures there. Fortunately, the failure rate's low, but I think in those cases as well, the donor nerves were very small and probably didn't carry enough axons either. So I think the takeaway is that when you do this, be sure that you're getting great input. And I think if I were to do that trauma case again, what I would do probably is I would do the operation, I would take a sample, and I would get some sense of actual number of axons truly in that. With like a PGP 9.5 staining or neurofilament or something like that. So if it didn't work, then I would have some indication as to why. And then in turn, I could maybe go elsewhere and look for a more robust donor. But that's the main thing. Got to have great input. That's my takeaway with that.
Of course, yeah, and I think that the same obviously is true in the extremities, and so thank you for that. I had a question about so when we do we do a fair number of endosides or reverse endosides or even end-to-end nerve transfers. Typically, when we're doing these nerve transfers, we're injuring or at least doing an epineurial window or injuring some fascicles to try to get some kind of growth. Can you tell us a little bit, not being familiar with the anatomy of the eye as much, can you tell us a little bit about the mechanism of what's happening in the eye? Because typically when you do a nerve transfer, you have an injured nerve on the other end, potentially if it's an end-to-end, or a nerve where you've kind of injured by doing an epineuridomy or something. Are the windows you create in the cornea, in light of the plexus of nerves, is that sufficient to have enough of an injury for this new nerve to grow down, or do you not even need that?
Yeah, it's a great question. So like what's going on in the end where these nerve fibers are coming out of the end of the nerve graft, and where are they going?
Right.
What are they? So normally in the cornea, there's no sensory end organ per se, So these are basically bare nerve endings. So they're unmyelinated fibers, and then they grow through the corneal stroma, and then some will come along, grow through the stroma like this, and then they'll pop up and then go into the epithelium, and then in the epithelium they'll interact with the basal layer of epithelial cells, and then also their interactions with the Schwann cells of that location. So they are kind of finding their way. With the images that I showed, from the rat with the green nerves and stuff, you can see that it's a much more disorganized sort of pattern of reinnervation. So I think they're probably finding new pathways, like de novo pathways, and I suspect that's probably the same thing that's going on, just from an anatomic geometric standpoint, in our patients too.
Got it. Great. Yep. And then a couple of questions about the corneal transplants. First of all, roughly what percentage of the patients are going on to receiving transplants? And also what's the typical timing of that? Like how long after you've done the neurotization are they a candidate for that?
Yeah, great question. So we've been fairly conservative, and we've set the bar kind of high, perhaps unnecessarily high, where we've said we want to have perfect reinnervation. So in other words, in this case, that would be 60 millimeters on the Cochet bonnet, so maxing out the scale in the cornea. And then we want to see that present by 1 year. So we want to have really high level of sensation, because we don't want to, have failures with the cornea transplant.
Right.
Because it's a precious commodity and so forth. So we've set the bar pretty high. And at this point, we've done about 8 to 10 cornea transplants post neurotization. Fortunately, maybe in part because we set the bar pretty high, all of those transplanted patients have gone on to do quite well. There was one patient who seemed to have some early immunologic rejection, so was actually put on, a lot of steroids, and then even FK506, believe it or not.
Wow.
And then subsequently got through it.
Got it. Wow, very cool. So I noticed that Professor Balakrishnan from Chennai, India, had turned his microphone on. Professor Bala, do you have a question for Dr. Borschel?
It's only a comment. An excellent presentation. I should thank you for bringing up this presentation. Incredible talk. It's a new armamentarium to the plastic surgeons in India. Thank you. Thank you very much.
Great. Thanks. Thank you, Professor Bala. Thank you so much.
Thank you, Professor Bala. Is anybody doing it in India that you know of?
So far, I don't know. I must ask my friends, after my colleagues.
Okay, if you find out, let me know.
Definitely, we'll find out and let you know. Thank you.
We also have a number of friends from Ganga Hospital joining us today as well. And so I'll ask Dr. Venkatramani potentially offline if they are doing it. And if they are, I'll definitely put them in contact with you. Because,
that's what it's all about. We want to really get everybody involved, and we need everyone's help, because nobody has like thousands of cases at any center, so it's definitely going to be a group effort.
For sure. I'm going to call on Dr. Greg Buncke for a question or comment. Greg, are you there?
Yeah, hang on. Greg, thank you so much. That's really a great talk. I commend your courage to operate in a part of the body that we don't do a lot of operations, especially in the, I mean, we do blepharoplasty, but never around the cornea, which is great. And then also for following through and doing the research necessary to really prove that it actually works and why it works. The question I have for you had to do with the technically, I don't ever operate using the microscope around the eye. Is there something about the ophthalmological scope that's different? Can we just turn down the amount of heat generated by the light? Is it can you turn down the illumination and use our own microscopes, or is it something different?
Yeah, thank you for that. Thanks for the great comments. And basically, our microscope is just tremendously bright compared to theirs. So it just makes sense to use theirs.
Yeah.
In fact, I never noticed this, but our ophthalmologist pointed it out. If you look on the side of our microscopes, it actually says not for ophthalmologic use. There's literally our microscope is ancient. It's like, I think it was made in West Germany, and you know what that means. But yeah, I think even the contemporary ones say the same thing, not for ophthalmologic use, for exactly that reason. It'll burn the retina due to the intensity of the light. So it may be possible to turn it down. I think there's, for you though, it makes sense to investigate that further, and there may be a filter that could be put on, because at your center, you would need to, I'm not sure how it would work from a workflow standpoint, but probably plan A would be use an ophthalmologic microscope, and then plan B might be apply a filter.
Great, thank you.
Yeah, thank you, Greg.
Greg, I wanted to thank you again for taking the time out of your busy schedule to join us today. This was really a fascinating talk, I think, and the number of comments that I've gotten in the comment section about this has reiterated that as well. So really a phenomenal topic, and thanks for all your work on advancing this very kind of specialized field.
For sure. If you want, I can hang on to address the written comments, or take them offline, whatever you like.
Yeah, they're all just, most of them are kind of comments on how it's inspiring, and they, they're just appreciating the quality of the work. There were a couple of technical questions, I guess. There was a question about, is it necessary to anchor the fascicles of the sural graft close to the corneal margins? I'm not sure if they saw the video that you had, but maybe you can comment on that real quickly.
Yeah, sure. So we think it's probably important to do it. However, we're open to the idea of using fibrin glue to put it in there. One thing that we're trying to do, and again, we don't know if this actually makes a huge difference or not, is trying to get the nerve graft translimbal. So we're crossing the limbus and then going into the corneal stroma. The idea being that the limbus, as we've seen in our laboratory studies, acts as a barrier to reinnervation. So if we can just anatomically and surgically just bypass that whole limbal barrier and put the nerve grafts directly into the stroma, we feel that it might make a difference. So that's it's still under investigation, but it seems like a low morbidity and potentially high value thing to do. So that's why we're doing that.
Got it. Well, great. Thank you so much again. Again, Greg, I look forward to hopefully seeing you in person soon. I know it's things are always up in the air with this whole COVID stuff. But I wanted to thank you again for taking the time to join us today. And thanks everyone for joining us from around the world as well. Fortunately, we will be able to have this recording of this talk on our webinar list at the Buncke Clinic's educational website, microsurgeon.org. So it should be up latest by tomorrow. Also, a quick housekeeping item. For those interested, today at 5 p.m. Pacific time, we have Professor Steve Moran from the Mayo Clinic discussing microsurgical reconstruction of the spine and pelvis. So hope to see you then as well. Greg, thanks again. Amazing talk, really inspiring, and it's been really an honor to host you.
That's great. Thank you so much, Babak. I really appreciate it.
Excellent. Have a great day. Sad, everybody.
Thanks, Greg.
You bet.